Okay, good evening, ladies and gentlemen. I see we are getting participants joining us for what is our fourth and penultimate summer webinar on behalf of the European Rhinologic Society. Today we're going to do something slightly different. We're going to try and run a roundtable session to discuss some of the complications of rhinosinusitis. I've got a number of real cases with some imaging, and we're going to discuss them as we go through, debate some of the controversies, and hopefully you'll get a few learning points taken from today's webinar. So we'll run for about 45 minutes to an hour. I hope to leave some time for questions. It's a real pleasure to have my panel this evening. I'd like to welcome Cecilia Ahlstrom-Emanuelsson who's a specialist in ENT from the University of Lund, Sweden. Christos Georgalas, who's professor in Nicosia and specialist in Athens, and Isam Alobid from the University Clinic associated with the hospital in Barcelona. So welcome all of you to our roundtable in the complications of rhinosinusitis. So we're going to start off largely with acute sinusitis. I just might add this evening we don't have Pavel Serda. Pavel unfortunately isn't able to join us, but as I say, I'd like you to ask questions hopefully as we go through the session. I'll pick those up at the end. And just to say that we're not using the chat function at all. So hand waving and chatting won't be of any use. You'll have to wait and answer some questions or ask some questions at the end. So let's move on to our first case, and these are all cases that you can expect to have to manage in the clinic yourself. There is nothing unusual about these. So here we have our first case. So this is a 6-year-old child who comes in to your outpatient clinic with a several-day history of that appearance there. A little bit of swelling on the lower lid, a little bit of redness there. And I suppose, Cecilia, what's running through your mind as possible differential diagnoses here?
Of course, the first thing I'm thinking about is orbititis or ethmoiditis, whatever you would call it, or normal conjunctivitis, depending on the condition of a child, if he has fever or is feeling in other cases. So that's the first thing I was thinking about.
Yeah. Are there any other conditions that run through your mind when you see a child with a sort of swollen lower lid or upper lid like this, as well as orbital infection?
Allergy.
Yeah, so it might be allergy, or there might be an injury to that child's eye, or I suppose even something like a dacrocystitis might produce something similar to that.
Or a stink or an insect sometimes. An insect stink.
Yeah.
Do something like that.
Yeah. And what sort of investigations are you going to do? Given the child's only 6, how are you going to assess this child?
If you're asking me, I would like to hear a little bit more about the history around the child. Has there been a fever? Has there been any cold? Has there been anything out in the woods? Depending on what different diagnoses we're thinking about. If it's a child with fever or have a history of cold or something, I would like to have an eye doctor to look at him.
Okay, yeah. And
of course, look into the nose, of course, but that's, of course.
So this child did have a bit of a pyrexia, a bit of a fever, also a bit of a runny, sort of snotty nose, a bit of a cold about 4 or 5 days ago. And you sort of mentioned you were going to examine the nose. In a 6-year-old, what sort of examination do you do?
If you're asking me, I look into the nose normally. I look with a fiber endoscope. I will look into the nose. And I will do maybe some CRP, looking at if there have been some infection. I would like, of course, I look at how he can move the eye, if he's have any pain or something. I would do some vision for what I can see. If I find it suspicious, I would send him to the eye doctor to have a proper look at the eye before I do any CT scans or something like that.
Yeah. Okay. And this child's got a nice quiet eye. It's not an inflamed eye other than those lids. How would you manage it? Let's say the ophthalmologist is happy with it. There's no particular concerns about vision.
No concerns about vision. He is okay.
Full eye.
Yeah. Then I don't know how does it look in the nose? If I look in the nose, is there any signs of any infection or something?
Bit of green coloured mucus, but nothing particularly specific. The child's not systemically well. The child's reasonably well.
Yeah. Then I probably just give him some nasal drops, maybe some corticosteroids and some peroral penicillin, I think. Yeah.
Okay. And would you give that orally, or would you keep the child in for IVs? How would you do all that?
If it's nothing in the blood samples or something like that, I will give it orally, but I will maybe see him the day after.
Okay. So get sort of safety net him.
Yeah.
Just in case anything goes the
wrong way. Yeah.
Yeah. And would you follow the child up, or would you just discharge them? And
yeah, but I will see him the day after and see what it's look like. And if it's going in the right direction, I won't see him again.
Okay. And if it's going in the wrong direction,
then of course I do something else. Maybe you have to put it into the hospital and give him some intravenous, or I will have to do a CT scan and see if it's an orbital infection or something like that.
Okay, that all sounds good. Okay, let's move on to something a little bit more juicy. Okay, so yeah.
Is this the first time, or this is a relapse of the
first time?
First time. Okay.
So let's imagine, because that's an interesting point. What happens if it's not the first time?
I think there is. For me? Yeah, maybe there is a defect on the papyracia or something wrong around it. If there is more than episode, so the management, we should try. I have a child with 3 episodes of the same eye. Then when you open the ethmoid and drain the mucus and make the a new approach to the endonasal, he's cured from relapsing.
Yeah. Okay. So you would do a ethmoidectomy, open up the sinuses, remove the bulk of the mucosa. Is there anything else that kind of go through your mind if a child is presenting for the 3rd time? Anything other than the sort of the basic appearance of the paranasal sinuses? Let's say the child is completely well between episodes.
Yeah, you talked about the dacrocyst before?
Yeah, it might be, as you say, an inflamed a dacrocystitis, inflamed lacrimal system. But I suppose the other thing is it might be an immune problem. If a child has a recurrent problem, then with orbital cellulitis, you might want to consider an immunological screen.
Absolutely.
Okay, let's move on to this one. Right, Christos, what about this one? This is a 32-year-old lady. What are the key features in the history that you think are important here?
Okay, the first thing is that the difference from the previous case, to start with, of course, it's an adult, but also there is a significant swelling and redness of both eyelids, and the eye is closed. And I would try first to open the eye to see if there's a degree of yes, exactly. To see if there is edema of the conjunctiva, which I think there is some starting early edema of the conjunctiva, which could be suggestive of pressure, increased intraorbital pressure. And, but okay, you said about, sorry, I'm rushing ahead.
No.
Part of the history, you said. Which elements of the history? So I would start, first of all, how long has this been going on? How is the patient systemically? She has high temperatures, she has a high fever, she's unwell. Has had a history of a cold recently, of an upper respiratory tract infection. Plus, eye-wise, does he have difficulty? Well, I will try to open her eye and ask her if she sees double, if she sees colors, of course, how can she see between red and colors, and if she feels that her vision has gone down. I would ask her to follow my finger and not only ask her if she sees double, but if that hurts. Sometimes people complain when they try to look laterally or medially, they get pain. And then look at the eye itself for proptosis, if it's bulging in front, and how's the mobility of the eye.
Yeah. In clinic, how do you assess vision? It's difficult pre-ENT.
It's difficult, exactly. I agree. I would ask for in this patient. I would certainly ask for an ophthalmology evaluation. Yeah. But from my part, when I would be in front of the patient, I would do some very basic adjustment. I can show here a green and red and colored clothes and try to see if she can tell the difference between the colors. And I would ask her just to follow my finger and ask if she starts to see double. When she follows the finger laterally, it's the medial rectus that is starting to get inflamed and it starts hurting, and it's not relaxing or contracting so well.
Yeah, okay. No, that's absolutely right. And Isam, what do you think about her eye when you look close up?
Dangerous case. I admit this patient to emergency department with ophthalmologist exploration and neurologic exam. I asked for CT scan and IV treatment. Okay. Waiting for the decision.
Yeah, and all of this sort of heaped up conjunctiva, that chemosis here. What causes all of that? Why did he get that?
There is the pressure from behind. It comes to the eyeball, and this is a sign of severe venous retention. Mm-hmm. So this is, I think, dangerous case because we have to act very fast and ask for a CT scan.
Yeah, because as you were alluding to there, the issue is the orbit itself, isn't it? It's a sort of pear-shaped bony box. You have the orbital septum coming down to the palpebral fissures. There's no space for expansion here. And then if it's left with increasing pressure, you get numerous sort of forms of or potential risk to the vision, from arterial thrombosis, venous congestion, optic neuritis, the whole lot. So it's a critical problem, isn't it?
Yeah.
Okay, let's move on. Christos alluded to the sort of various forms of assessing vision. You can use a Snellen's chart, or the first 14 plates of an Ishihara chart can be useful. And then you were sort of talking about the red and green color vision. It's red color vision that goes first, isn't it? Mm-hmm. And you can ask them to compare it through a slit, looking at the good eye and the bad eye, and they talk about the red color being washed out, don't they, in that in the affected eye, if there are any early concerns about vision. So we just go back, Isam, I'll let you take this forward. You were talking about imaging. What sort of imaging would you request?
Sorry. I asked for CT scan.
Yeah.
At least in our institution, it's faster than MRI.
Yeah.
It gives me more information at the beginning, because if you can see in this patient, we can see that there is.
And this is a left eye.
Left side. Yeah, it's the other side.
Abscess.
So this is the left eye here, and we've got.
Yeah, subperiosteal abscess.
Yeah.
And complete opacification of ethmoid and maxillary sinus.
Yeah.
So
Okay. Now, before you say anything else, what I'm going to do is I'm going to do a poll of the audience, and I'm going to ask them, the audience, in this particular case, can we manage this with antibiotics and that surgery is not needed? So the panelists can vote as well. If you'd like to start your vote, we'll give you 20 seconds to vote and see what...
Nice.
is there any option for both of them?
Both, yes.
So this is... I think we've got almost everybody has voted, so we'll end that there. If I share the results, can you see that?
Oh.
So that's interesting, isn't it? We've got 37% of the attendees think we can manage this with antibiotics and that surgery is not required, and 60% feel that it needs surgery. So about a third, two-thirds split. Christos, what would you do in this particular case?
No, I don't. I don't agree. I would most certainly operate, and it's not my opinion. I think also I was requested to write the part of complications in the EPOS, the previous, not this one, the previous EPOS, and also in the ICOS. And I looked at the literature. There is just one study from Israel, which is in young children, I think younger than 5, that supports the use of antibiotics in the case of subperiosteal abscess. And in that small subgroup, which is young children less than 5 years old, with small abscesses, less than 2 mLs, which are medially. I don't think there is any other, as far as I know, right, from the literature research that I did, there is no other study that confirms the use of antibiotics if there is a demonstrable abscess, a clear abscess in an adult, again, not in a child, in an adult. So I think once the abscess is formed, irrespective of whether it's improving or not improving, even if it's, yes.
Yeah.
But
the literature's moved on a little bit, but absolutely. So if it's a less than 1 ml in volume and there's no concern about visual disturbance or immediately placed, and it is medially placed, and if we just go back, it meets some of the criteria. It's medially placed. It is at least 1 ml in volume, but this is the worrying thing, isn't it? This looks like a really tense globe. So I think, hands up panelists who would operate. Yeah, okay. So the panelists are going to operate on that one. Right, let's move on to our next poll. So if you're going to operate, how would you operate? My question is, in a subperiosteal abscess drainage, which approach would you use to drain this abscess if we are going to drain it? Are you going to drain it through an external incision, or are you going to drain it endoscopically? And I suppose an external incision, you can do the skin incision, or you can go through the caruncle of the medial orbit. So if we launch that poll, and if the audience would like to tell us how they would do it. Can you see the poll as it's happening?
yes,
Yeah.
I voted, just voted.
I already voted.
Good. So it's looking like the majority of people thus far are going to be doing it endoscopically. We'll end the poll at that point there. So we've got more than 2/3 voted, about 3/4 voted, and we've got an 86% endoscopic transethmoidal approach. Do you think that's reasonable?
Yeah.
Yeah. Do you think there's a place for external incision?
So we are very familiar with endoscopic sinus surgery. It's easier for us as endoscopists or rhinologists to do going through the canaliculus or external approach is not wrong way, but if you can do it endoscopically, it's for us. It's and the place that in this lady, it's medially, and you go directly to the papyracea. You remove the papyracea at this point, and you remove the abscess. So, yeah. I think it's safer in this case.
Yeah, I suppose for experienced rhinologists, then yes. But if you're very inexperienced, the most important thing is to be comfortable in your drainage of the abscess. And if that means that you need to go externally, and that's the way you've been taught, and you're not experienced as an endonasal surgeon, then that's certainly a reasonable option as well.
I agree. I mean, as long as you drain it, it's fine which matter you go. But just one more argument for the endoscopic approach is that you deal with the source of the infection. So yeah. Not only you drain the abscess, you can open the ethmoids, you can open the maxillary sinus. So you deal with what caused it. Plus you create an open corridor that can keep on draining. Outside, you drain it once. If it accumulates again, you cannot leave a drain. Normally people, I don't know, I mean, most people will not leave a drain, which means if it blocks again, it stays blocked. Unless you do an external ethmoidectomy, but I don't think a lot of people would do an external ethmoidectomy at the time.
But if you leave a drainage from outside to inside the nose, you can do that. It could also be drainage for quite a long time, but the scarring won't be especially nice, especially for women in that age.
Scar, of course, yeah, but yes, the scar as well.
Yeah, and sometimes it doesn't heal very nice.
No, if it's infection, it doesn't heal very well, especially if you're an adult person.
Okay, let's move on to our next case. Right, let's assume that we've got that eye, that orbit. You saw the CT, you saw what the globe looked like, but on the CT, in fact, there was no pus. So how do you manage that? It's an angry looking orbit, but the CT doesn't show any pus. So it's a good quality CT. This is the left eye. You can see the edema, but there's no pus visible on that scan. What do you do there, Cecilia? How do you do that? It's not an easy one. How do you do it?
No, it's not the easy one, because I would like to operate it, but if it's no pus, I'm not sure I would like to go into and operate on that. Then maybe at least if vision is okay for the patient, there's no vision loss or color loss, I would like to try to give intravenous steroids or parasteroids and antibiotics in high doses for 24 hours and see what's going on.
And really close eye, excuse the pun, by the ophthalmologist.
Yeah, absolutely.
Okay, yep, that's fine. And perhaps if the vision does deteriorate or there is no improvement, then maybe rescan.
Absolutely. Okay. Or maybe I try to do an MR if I could get that. Yeah. I would like to have an MR.
Okay, this is a slightly different one. This is a 17-year-old male. The black is to anonymize him completely. He's had a 3-day history of progressive swelling around his orbits. He's pyrexial. He's quite septic. He's actually, it's difficult to examine his eyes, but you think when you examine him, he's not really moving that left globe laterally. It looks like he might have a sixth palsy. So what's kind of going through your mind here?
Sinus canalitis, thrombosis.
Yeah, okay. And Isam, what are you going to do in terms of investigating him?
Angio-MRI.
MRI.
Angio.
MRA. MRA. Yes.
MRA. Okay. Anybody do anything different? Would you CT it?
MRI angio. Yeah. No.
if I'm thinking about cavernous sinus
both of them.
and of course angiography, and plus you will see also the ethmoids, and you can get an idea about the orbit. But thin slice, I would ask for a thin slice MRA.
Yeah.
1 millimeter. Yes.
So here, I mean, we can see he's got bilateral signs, so that really does raise the issue of cavernous sinus thrombosis. He did have a CT to begin with. And in the early features of the disease, CT is reckoned to be can be quite helpful. Can you sort of, how would you report that CT? What sort of features on it do you think are relevant?
The sphenoids?
Yeah, so you can see he's got complete opacification of his sphenoids and of his left ethmoids there. What about his cavernous sinuses themselves? It's a bit unfair maybe to ask, but
because there is contrast, so you can see there is some contrast in the area of the cavernous sinus, but to be honest, I cannot tell if it's the venous phase or the arterial phase, and whether that is proof of you know, a reduced flow in the cavernous sinus or not. I couldn't say.
And there's a bit of irregular enhancement, isn't there?
Yes, true.
Attenuation, I should say. And so, you know, those could be filling defects. And this here, what's this?
Wow, yes.
Ophthalmic vein.
Yeah, so that's one of the ophthalmic veins is dilated. It may well be thrombosed, which again is a sort of feature. But you pointed out the MRI or the MRV, a sort of angiographic assessment. What we go over here for people is just the sort of appearances of anatomically of the cavernous sinuses. This is a normal appearance, and this is the child in question. And you can see there are some subtle differences. Christos, do you see anything there that?
So this is the, let me see, I'm just pointing here. There is enhancement. The left sphenoid sinus seems empty. On the right side, there is enhancement. But this is the venous phase. So, and also I see, of course, the pituitary stalk, and in the area on the right cavernous sinus, there seems to be some irregularity. I can see there is the filling defect of the, but that's the carotid, and there's enhancement laterally, yes, on the area of the cranial nerves, on the lateral side of the cavernous sinus. When you have the sixth nerve, you can see there is certainly a discrepancy between the right and the left side. And
those carotids are a bit narrowed as well, aren't they, compared to what the normal appearance is? So this is a really nasty infection. So we talk a little bit about management principles. How are you going to manage this? Christos?
IV antibiotics, there is discussion about, I think it's a very rare complication. I would definitely ask for the advice of the interventional radiologists and the neurosurgeons. It's something that we don't see often, so I would most certainly ask for their input. I know there is some argument about using or not using anticoagulants, so something to think about. Also, there has been a discussion about the role of interventional neuroradiologists. Certainly antibiotics, and most likely, yes, that should be it. IV and third generation, which is the same Rocephin, ceftriaxone, which we use for intracranial. And the discussion about surgery, yes, I think it's the easy way out. Let's say it's something that to clean the sphenoids will not do any harm. Certainly, the sphenoids look opacified. There is a source of infection. For a rhinologist, it's a half-an-hour procedure. It's not a big thing. You can clean the sphenoids.
So going back,
will that help with the venous thrombosis? I'm not sure.
So what about all of this? Would you do the ethmoids as well on that side?
On the left side, yes, if there is pus. I mean, decide to go in, and it will not really change the surgery or the timing that much. It will be messy and inflamed and parallel, bleeding, but yes.
So just to take a quick poll of the panelists, who would operate on this early and who would treat with IV antibiotics for 48 hours? Who would go in earlier than 48 hours surgically? I would operate. Yeah, so I think surgery to drain, obviously, the site of infection. Steroids, perhaps if there's any suggestion of pituitary failure or cranial nerve deficits, And you alluded to anticoagulants. What we'll do is we'll just take a poll, because that's an interesting one, about anticoagulants, because it's pretty controversial, isn't it?
Yeah, but we're using it.
Yeah. So what would people do? You know, because there are risks, significant risks with bleeding. Perhaps if you're going to operate, you can't put people on anticoagulants perhaps straight away. You may have concerns about stroke. But then on the other hand, what about the thrombus itself? So we're racking up the numbers here. We'll give you 10 more seconds to complete the poll.
That's fast.
Very good.
They're very active.
So there we go. The majority of people would agree with anticoagulation, but I think in the caveat being discussion with all the members of the team.
But the thing is, I would like to operate before I give full anticoagulants.
Yeah. Okay. So stop sharing that.
So in this case, young lady, yeah, with no past history of any another disease. I discussed with internal medicine about the side effect of anticoagulant, but I think for us, from ENT view, I think it's indicated in this lady.
Yeah, I mean, you're trying really to prevent the thrombus propagating, aren't you? If it's taken off, then the concern that you're going to get thrombosis in other parts of the dural venous sinuses as well, which clearly is life-threatening. Okay, let's move on to this. So we're going to move away slightly from orbital cellulitis, but let's assume that we have one of our patients there, perhaps the patient with the major orbital swelling, whose cellulitis resolves, but then she gets further headache, or her headache doesn't resolve. What are you going to do? So she's had a CT, she's had the pus evacuated from her ethmoids, her orbit is getting better, but her headache persists.
I would do a CT. I would think of intracranial complications.
New CT scan.
Okay, so she had a CT scan with contrast and it doesn't show anything.
How are her clinical signs in terms of the inflammation signs?
She's
White
fine.
She's going down.
Just got a headache. Nothing else. A little bit of pyrexia, but not much else. There's a space here for something else.
MRI. Yeah.
So what do you see there is
abscess?
Yes.
Yeah, small
abscess.
Abscess after that. Yeah.
So she's got a small abscess. What do we do about that?
I would try. Probably I won't operate in that first case. Antibiotics first.
Okay. Yeah.
I would ask the neurosurgeons, and I think they would answer that they wouldn't do anything, most likely. In a patient who was well, had no symptoms, but I would definitely ask for their advice, the neurosurgeon's advice.
Isam?
So you said that in general, the patient improve and get better. So
no neurological deficit.
I go for long-term antibiotic.
Yeah. Okay. I think the panelists are all agreed. Would you rescan this at some point? And if, how long would you leave it before you rescan it?
If the patient was well, I would probably rescan it in about a month. If the patient was apraxial, no inflammatory markers, if the headache improved or stayed the same or didn't worsen in any case, I would probably order 2 weeks. Maybe, but again, I would judge it with the neurosurgeons. I wouldn't take the decision on my own.
Okay, so
probably at 2 weeks, I would say. Yeah.
Sam, how long would you leave between scans?
Couple of weeks.
Couple of weeks. Okay, that's fine. Let's move on. All right, now this is an interesting one, because this one is only a few weeks ago that we had this case. So this is an 18-year-old male who presented with let me remind myself. Yeah, presented with headache and pyrexia and a mild frontal swelling here, and a bit of swelling over the bridge of his nose. He'd had a previous respiratory infection. He came into a hospital that didn't have an ENT, dedicated ENT unit, and he was admitted for intravenous antibiotics, and actually he got better. Would you manage this medically, or would you manage it surgically?
If he gets better, I will wait, but I wouldn't hesitate to operate on that if it's stable or doesn't get worse.
Okay. Interestingly, his on his initial scan, something was missed there, which is an area of meningeal enhancement. So this was the same scans, but that second image wasn't picked up by the reporting radiologist. Would that change your opinion when he presented? If he had meningeal enhancement at presentation, would you treat him with intravenous antibiotics and watch him, or would you operate on that frontal sinus?
I would operate.
Isam?
I operate as well.
Yeah. Christos?
The same.
Yeah, okay. It's interesting, as I said, he didn't get an operation. His pyrexia settled, his headache settled. He was absolutely fine. He went home on oral antibiotics to come back in for another scan. He came back in for his scan, and as he was wheeled down to the scanner, he had a seizure. So he was intubated, ventilated, and had this MR scan. What do you reckon to this?
Yeah, exactly. I had a very similar case with a young girl, actually, a 16-year-old girl. Long history, some headaches, doing well, and then this image on the MRI, very impressive, with a collection. And usually these patients have also post-puffy tumor, have also some swelling in front, in the soft tissue anteriorly. Yeah. Apart from also the collection empyema, the intracranial empyema, and the frontal sinus opacification, the frontal sinus empyema.
So this is a subdural empyema over the top of the brain itself, and you can see the inflamed frontal sinus there. And I think it just emphasizes how significant frontal sinusitis is. Isolated frontal sinusitis is rare, but it can still be a killer, even if treated very aggressive medically. So it's really important, as we, as the panel here agreed, we would operate on this. And we talked a bit about, I'm going to ignore that approach. We've kind of talked about approaches, but yeah, how would you, no, I will, I'll ask you that. How would you approach that frontal sinus to drain the frontal sinus? Would you do a trephine of the frontal sinus externally, or would you do it endonasally?
Endonasally. We published our series as well with intracranial complications treated endonasally. About 8 cases, I think we had.
Okay. Cecilia?
I think if it's an acute infection and it's on a weekend, I would do external, I think, because it's quicker and easier and can get a good drainage from that down. If I operate it endonasally, it's quite infection and it could scar again. So I probably do it external and put some drainage in so I can get some rinsing it daily.
Yeah. Okay. And Isam?
I do draft type 3 directly.
Would you?
In acute?
Yeah.
Right.
Yeah.
I think, may I say something, Mike? Because we had this discussion many times before. May I? It's basically, I think what Cecilia is right about. By going externally, you don't operate in an inflamed area. You avoid the risk of scarring. On the other hand, if you do it endonasally, yes, you have a big risk of scarring at the second stage, but you provide a drainage pathway that will stay open. So in our series, what we saw, on one hand, we had less morbidity, intracranial morbidity, by doing an intranasal drainage at the same time as the neurosurgeons did the external approach, but we did have a high revision rate. At the second stage, we had these patients cured from the frontal sinusitis, but presenting with scar tissue and blocked frontal sinus that necessitated the second stage surgery. So I think this is the argument. We had a discussion with them.
Isam, why a draft 3 and not just a small opening into that frontal sinus to drain the pus? Because it's not usually a problem with the mucosa or the anatomy. It's just a very virulent infection.
Just avoid what Christos just said about scars. If you do small hole, for the second day you have closed the... So if I do open hole, I do more cures, aggressive cure to avoid scars. And in this case, I maintain the both sides opening, just in case there is retention in one of them, there is a second way to go out.
Okay.
And there is no big difference between 2B or draft type 3. So that's open in between and remove the septum in between both frontal sinus. So for bleeding and inflammation, if you remove the mucosa and you coagulate it and you remove it with the drill, the inflammation goes. On the first ring you remove the inflammation. And in my hands, I have few cases with acute infection, but I think this approach avoids scars and revision surgery in my hands.
Well, what I'm very pleased to see is that the 3 panelists don't agree. And that's what we wanted. We want a little bit of controversy. And I think it comes back to what we were saying, whichever way you can do this most safely is the most important factor. Okay, let's move on to our next case. So this is a 12-year-old child, again, not that long ago, presented to our institution and basically presented with sinusitis and a little bit of periorbital swelling, which settled down very quickly on antibiotics, but had a persistent headache and a little bit of ongoing pyrexia. And you can see there, this child actually has an epidural abscess. It's a sort of bilobed abscess. So this component here, this component here. The images don't show it very well, but this child didn't have any developed frontal sinuses. So, and a pacification of the ethmoid. So the neurosurgeons asked, can you drain this endonasally for us?
Interesting.
This is not a 52-year-old man. This is a 12-year-old child. But I'd be interested what the panel say. Would you drain this endonasally?
I would like to see more posterior images, basically, to see if there is any space in the cribriform. How far back? Do you have any other? No,
I mean, those are only 2 images you're going to get to see, Christos.
Nothing else. I haven't done it. I wouldn't do it personally.
But the sagittal cut is taken through the apex of that swelling. So it is just about over the roof of the ethmoid. That was sitting just above the roof of the ethmoid. Sam, it looks like you're thinking you might do this endonasally.
Come on.
I need more studies for it. So.
Okay.
A difficult case.
Yeah. So we tried, but the access was very narrow. That was the problem. It was a 12-year-old child, and it was a difficult access. And I must say, I buttoned out. I said I'm not happy to carry on. But they did it through a small trephine in the hairline.
For the neurosurgeons, I think it's 10 minutes work. 10 minutes work. It's really easy.
Yeah.
little trephine in the hairline, and then a catheter down to drain it. Okay, so okay, that was that one. Right, a poll, our last poll of the evening. This is stop sharing that. Our last poll is multi-choice. Which of the following are risk factors for intracranial infection? So I'm going to launch that and ask you which are the risk factors.
Wow.
Frontal sinusitis is racing with. There's not just one answer here, more than one.
Okay.
Right. Okay. So we've got about 3/4. We'll end it there, and you can see the results there. So female sex is not deemed to be a risk factor. Adolescence, potentially. Frontal sinusitis, most definitely. Left-sided, not. So if we stop sharing that and move on to the next slide, I've just summarized these here. So looking at a sort of summary of the studies, if you're male, if you're adolescent, and particularly if you've got frontal opacification on CT, your risk of intracranial affection associated with orbital cellulitis is greater. And certainly in my experience is that younger males in particular tend to have aggressive disease and need to be managed very, very carefully. Okay, so moving on from frontal sinusitis, if you wanted a little bit of a guideline on management of orbital cellulitis, I direct you to this one here, the ENTUK one, which is a nice flow chart on how to manage patients. I'm going to, last couple of slides to finish before we take some questions. This is a 14-year-old lad, Cecilia. He's got basically a 5-day history of a painless swelling in his forehead region, a little bit of edema of his right upper lid. How are you going to assess and manage this?
I will guess I will do a CT scan on this patient as the first thing after normal examination, with look into the nose, look into the eyes, open the eyes, see if he can move the eye, and if he has lost any, for me, obvious vision or color vision.
Yeah, the vision is all good, no problems.
And it's been no injury, any accident or something, nothing, no.
What's running through your mind as the differential diagnosis here?
I think about, as I had before, pot-puffy tumor, of course. Yeah. I'm thinking on, and I'm thinking about some injury in any way, however, or some of this, as we talked before about this insects or something, some bite or something has happened up there. Look around.
You're quite right. He's had an episode of sinusitis. He's got a bit of mucopus in his middle meatus on both sides, and he's got that swelling there, which isn't tender. It's not really very painful. It doesn't look particularly inflamed. You CT it, and he's got frontal opacification. I wonder if we've got any. Yeah, that's his sinus there. Just a single view. Christos, how are you going to manage that?
I would ask for a CT. I would think about post-puffy tumor. I would try to see if there is erosion on the anterior plate of the frontal sinus, and usually in the posterior. Here, you see the erosion on the posterior plate of the frontal sinus.
Yeah.
Which suggests the communication with the brain, basically with the intracranial contents.
Yeah.
So would you do anything? Would you do any
MRI?
MRI, okay. And why are you doing an MRI?
Because I want to see the communication. Is it just erosion or there is an intracranial collection? and
Yeah.
what type of collection is there.
Okay, that's fine. And Isam, how are you going to manage it? What are you going to do for him? Let's say that the dura is intact. There's no intracranial inflammation.
IV antibiotics and surgery.
Right. Okay. So when do you time your surgery? When do you do your surgery, and what do you do?
Frontal sinus surgery, maybe draft type 2, and post-op control.
Yeah. When do you do your operation? Immediately? When he comes in, or do you wait?
Maybe couple of days. If there is, the MRI is fine, and the general is good, and no signs of alarm.
Christos, what about you?
Yeah, I would give him antibiotics for, well, I would try to see the MRI, what happens intracranially. And let's say just erosion, no collection. Give him antibiotics 24 hours and then get him to theater. And just to make my life easier, I think the surgery will be easier if he's had some antibiotics before. Okay. And plus it will help the healing postoperatively.
And your surgery, what are you going to do?
I would do a draft. I mean, it's only here. I would do a draft 2A. I would just do a frontal sinusotomy. Okay. And
Cecilia, any place for just prolonged medical management and no surgery?
No. Difficult. I wouldn't wait for a long time. Maybe just 24 hours and give antibiotics and see what's going on, and some steroids too. But I think he was just 12 years old, or how old was he?
No, they're all turning into one. He's 14, this one.
14, okay. Maybe I do, as I said before, I will do an external and put out the pus just from a frontal sinus and don't do anything more.
Okay, on one side or both sides?
If it was it osteopathy of both sides, I just do it on the side where it was a puffer tumor.
Okay, that's fine. Well, I like to see that. That's three reasonably separate answers again. So a nice little bit of controversy there. We've got one last one nice and easy one to finish off with. This is a unilateral maxillary sinusitis that's failing to resolve. This patient's got dysosmia, purulent post-nasal drip, and it's been going on for 3 or 4 months. She's had antibiotics thrown at it regularly by her primary care physician. It's just not getting better.
Go to a dentist.
So absolutely, go to the dentist. Now, the question is, do you send her to the dentist to have her teeth sorted out, or do you do a middle meatal antrostomy? Which one first, or which one only?
I would do both.
You would do both. Which one first?
Which one first? I would do the antrostomy first.
Okay.
Why? I would do. I mean, I don't think it's a good right and wrong answer. You can also say the dentist first, but I think that if it's closed and the opening of the ostium stays closed, she risks getting a fistula, an oroantral fistula, if the cavity stays closed, and you deal with the abscess. Probably, I don't know, they take out the inflamed tooth or they do some dental work. The risk is that there will be a communication. I think that it's helpful for the healing down at the root area to have some space medially as well.
Okay.
Drainage of the pus.
But she might actually just get better taking the tooth out, mightn't she?
She might, yes, true.
It goes quicker to go to the dentist to get the tooth out than get into the operating theater, at least today.
Sam, what would you do? Would you do teeth or sinus first?
Actually, dentists refer this patient to us to do surgery first, then they do the dentist work.
Okay, I think there's a place for a study here. Clearly we don't have the answer. Okay, right. I'm going to finish it there because we are at 5:02. I think we've got a couple of questions. So if you give me a second. So we've got, yes, we've got a question. Why do we use green and red color for assessing orbital vision? Does anybody want to pick up on that one? Why do we use colors, and what's important about color? What's the importance about color vision? Come on, Christos, why do we?
I know we do it. To be honest, one of the earliest indicators of optic nerve damage.
Yeah.
But why is that color vision one of the earliest indicators? I'm not sure. I know that
must be the cells of the rods, is it? That
the rods and the, yeah, something.
The red rods must be the most sensitive. So that's one question, and the second question is, Sean, do we get a certificate for the webinar? So I don't think I need to put that to anybody. I'm afraid no, there is no certificate. So
for us.
Yes, you got a round of applause.
We did the cookie. Thank you.
So, ladies and gentlemen, I hope you've enjoyed this evening's webinar. I hope you enjoyed the cases and the panelists. I'd like them to thank them all for taking the time to get involved in this and for sharing their views. It's been, I think it's been a nice session. We've seen some cases. We've had a little bit of agreement, a little bit of controversy. We are at about an hour now, so I think it's time to end the session. I'd like to thank you all. We have one final webinar for the ERS juniors in a couple of weeks' time. You'll get some publicity about that sent around shortly. So from us all here, good evening and stay safe.
Thank you very much for the invitation.
Thank you very much.
Thank you.
Christos, Cecilia.
See you.
See you.
Fantastic work. Thanks a lot, son.
Thank you for all.
Thank you.
Thank you.